2025 DD Council Training Technical Assistance Institute was planned by a group of your peers. And one of these that I'd like to introduce to you is Lillian Deja. Lillian is from Broussard, Louisiana, and serves as the Louisiana Youth Leadership Forum Coordinator, which is a leadership program for high schoolers with disabilities. Prior to taking on that role in 2023, they served as the senior coordinator at the Governor's Office of Disability Affairs, tracking legislation and advising on voting accessibility issues, and providing analysis on disability-related legislation to internal and external policy teams. Lillian?
Hi, everyone, and welcome to our session 2. I hope you guys are having a great afternoon. So you have joined the session titled Supporting Healthy Communities, Positive Impacts and Approaches. And during the session, you will hear about the successful efforts your council peers have been working on to improve health outcomes for people with intellectual and developmental disabilities in their states and territories. I'd like to introduce you to some of our speakers today. Kevin Vargas joined the Washington State Developmental Disabilities Council as the Contracts and State Plan Coordinator in November 2023. Brandy Motz has been with the Washington State Developmental Disabilities Council as the Executive Director since September 2022. The Snohomish County Public Health Team is represented today by Kari Bray, the Communication Director for the Snohomish County Executive Office, Nicole Thompson, the Public Affairs and Policy Manager, Sasha Koren, an experienced graphic designer who serves the health department by developing print and online materials to inform and educate the public, Todd Holloway, a senior independent living advocate for the Center of Independence in Lakewood, and Helen Wong, the health equity policy analyst with the Snohomish County Health Department. Then we also have Liz M. Candelero. She began working with the CEDD, which is the DD Council in Puerto Rico, as the lead planner, and is now the executive director there. Alexandra M. Mojico is the senior attorney on staff with the CEDD. Chris C. Ashley is the executive director of the Mississippi Council on Developmental Disabilities. And Dr. John Behrens is an assistant professor of medicine at the Baylor College of Medicine, and he is both board certified in internal medicine and pediatrics. Since completing his residency, he has worked as a primary care physician in the Transition Medicine Clinic, which specifically serves adults with intellectual and developmental disabilities. And those are all of our speakers for today.
Great, thank you. So the first people who are going to present are our Washington State Developmental Disabilities Council. So Kevin, you can take it away.
Thank you so much, and thank you for the introduction. Hi, everyone. My name is Kevin Vargas. As mentioned, I work for the Washington State Developmental Disabilities Council, and today we have the opportunity to share with you all a cool project that we conducted last year in 2024, which was called the Guidance for Improving Accessibility of Public Health Communications. Pretty much, it's a reference for communicating with residents with intellectual or developmental disabilities. Next slide. So I'm just gonna give a little bit of background on how this project came to be. In mid-2023, the Washington State Developmental Disabilities Council received a federal award to address the expansion in public health. Our council then voted on making a competitive process, putting out an RFP for creative and innovative ideas to expand and prepare the future health challenges that our community with developmental disabilities may face. The Snohomish County Health Department was actually awarded this grant and subsequently went on to create a guide on how to improve government communication with residents who have intellectual and developmental disabilities in an effective and accessible way. Next slide. Next slide. Awesome. And I'm going to pass this over to our Executive Director, Brandy Mons, just to give a little bit of background and influence on this project.
Hi, everyone. I'm Brandy Mons with the Washington State Developmental Disability Council. Thanks for having us today. the moment in time when this project was starting was a really great moment in the history of Washington State and added a couple really cool elements to this program. So there was a bill, House Bill 1541, Nothing About Us Without Us, that the developmental disability community was working on at the time, as well as the Office of Equity, which was established inside of our governor's office. And really, what that bill and effort did was to say, we want to make sure that we include people who will be impacted by government work at the table when we design, whether it's a toolkit or whether it's a council making, decisions about how folks' lives will be better. And so the Office of Equity put out some established guidelines for how to do that, in particular, compensating people for their lived experience as a subject matter expert. And so the Snohomish County Public Health was willing to take this on in this project and figure out how public health that sits inside of our county government system in Washington State would be able to pay folks more than like a $20 gift card or a $30 stipend, which has historically been what folks have received. And this goes into for some folks it goes into their benefits and understanding how it impacts their benefits. And so it was a great opportunity for our public health system to figure that out and then compensate folks that were part of this project for their contributions in the project. So the Nothing About Us Without Us bill, I'll put into the chat. And then the community compensation guidelines, I think you'll get this stack. You'll be able to go look at what our office around equity has been doing to compensate folks for their lived experience in government work. And last plug I'll just say is this was super cool for the council to watch because we're trying to do this every day, right? We're trying to bring people with developmental disabilities into our work and help them really understand whatever the topic is, and then make informed decisions to help guide the work that we do. And when I see that happening in other parts of government, it makes me feel like it's such an awesome moment that I'm so humbled to be part of. So thank you.
Yeah, awesome. Thank you, Brandy. And next slide. One more. Awesome. And here, I'm going to actually pass it over to our friends at the Snohomish County Health Department, who's going to give us more, who's going to dig more into the actual project itself. And I'm going to pass this over to Kari Bray.
Thank you so much, Kevin and Brandy and the whole team. This was an incredibly rewarding and wonderful project to work on, and we're really grateful that we had the opportunity to do this. And I want to thank the organizers of this event for inviting us to present today as well. So I'm Carrie Bray. I'm the Communications Director in the Snohomish County Executive Office, and at the time of this project, I was the Communications Supervisor with the Health Department. So you can see the cover of what the end result of this project was, which is a guidance document focused on improving accessibility of public health communications. And one really wonderful thing here is that while we focused in on improving accessibility of communications for people with intellectual and developmental disabilities, the reality is when you improve accessibility, you improve it for everyone. And so this is amazing guidance to shape our communications with anyone in our community to make them more accessible and more digestible for people who are trying to learn about their health and their community's health. Next slide. So here is just a quick summary of the presenters. We had a wonderful introduction earlier, so I won't linger here long, but I am joined today by some wonderful folks on my team. They can give a brief introduction as I kick various slides over to them. Also, the guidance document itself early on has a full list of all of our internal work group and the external partners who participated in our advisory group. So I do want to say, while we have a great group here, there were a lot more voices involved with this, and we could not have done it without them. So for a full list of all of the amazing folks who helped make this possible, that is in the guidance document as well. I think we can move on to the next slide. So this is about why we did the project. And for this, I would like to invite Nicole to jump in because she is one of the early folks who kind of raised her hand and said, I think we could do something really cool with this.
Yeah, thank you, Carrie. So Nicole Thompson, as previously mentioned, I'm the Public Affairs and Policy Manager. It's a bit of a misnomer about what that means. It sounds very specific, but in my world, I actually managed roughly about 9 programs. And at the time of this project, communications was one of the scopes within my umbrella. So the health department writ large has had central to its mission equity and inviting community members and centering in on community. Now, of course, our ability to operationalize that and actually implement that has changed as we grow, and it's all good and fine to put those words out on paper, but the implementation of them is often, as we all know, sometimes more of a challenge and creates more obstacles for us to work through in actual implementation. And so for us, this opportunity was one way and one avenue that we could, nothing moves mountains like money. And so when an opportunity comes about to really make some changes in a more focused and intentional way, it's always a good opportunity for us. And so this particular opportunity was one of those that I think really moved and changed the conversation in a way that we're learning from our COVID experience. As a leading edge, we learned as a health department, as many of you may know, Snohomish County was the first one in the state to have an active COVID case in it, first in the nation for all sorts of things related to COVID. And one of the lessons that we learned through that, amongst many, was that we were not meeting our communities where our communities were at in a way that our communities needed us to show up. And one identified community where we were clearly not meeting those goals was our IDD community. So this opportunity really galvanized several things for us that we needed to take action and change. So just very appreciative of the opportunity and the DDC for having this opportunity come available. Next slide. And I believe this is back to Carrie.
Yeah, I'll jump back in a little bit more and talk about how we did the project. So, shaping up this project, the first kind of groundwork we laid is we needed to bring together an advisory group who could bring those voices to the table. When you talk about nothing about us without us, these are the voices we need to shape this work. And so we did that by reaching out to community partners. So there are some amazing organizations, nonprofits, community groups that do work existing in our community and have these connections. And so we cast a pretty broad net and reached out and we said, hey, here's what we're looking for. Here's what we're doing. We have this grant opportunity and we need an advisory group. We would like nominees. We would like a mix of folks. We want people with lived experience. That is a high priority. We also want people who work in this space and are professionals in this space, and service providers. We want caregivers. We want people who can bring a variety of voices. So we accepted nominations from our community partners, reached out to those folks, and they accepted to join our group. And so we had a really wonderful mix of people who worked in the space professionally. Some of them had lived experience and worked in the space professionally. We had folks with lived experience, and we also had folks whose lived experience was as a caregiver or a volunteer working with a loved one in spaces like Special Olympics. So we really had a good mix of folks on that advisory group. We then did some initial research of existing resources. One thing we've consistently heard from communities is when you show up and you have nothing and you just say, okay, tell us all about everything, that's not fair to them. It shows that you didn't bother to do the research and look at what they have already put out there, the work that's already been done and that they've informed. So we started by researching existing resources and taking extensive notes on what was out there and what we thought would be helpful. And then we outlined the topics that we would like to cover in our guidance document. And when we launched our meetings, we held monthly advisory group meetings. And at each meeting, we would focus in depth on a section of that document, on the notes from existing resources. And we would have specific questions we talked about. What here works? What makes sense for this community in Snohomish County? What doesn't make sense? What are we missing here? And so rather than coming in and starting from scratch, we came in with what was out there and asked the group to help shape it to something that made more sense for this group in Snohomish County. And all of those meetings were held hybrid. So we had a virtual and an in-person option. And that was based on a survey we sent out initially asking the whole group about accessibility needs. And the preference was, to host these meetings hybrid so that people could be there in person or virtually. In the end, we came up with a final document based on all of the notes from those meetings and all of the input. We brought that final document back to the group, did a review, and then we tested it. So we brought a sample campaign actually from our COVID outreach, and we said, here's what we did. Looking at this work we've done on this document now, how would we apply it and what will we change? So it was kind of our chance with the advisory group to test that document in a real world situation and make sure that what we thought would be a helpful resource would actually be a helpful resource. So it was really fascinating. The group was wonderful, and we ended up with what I think is a very helpful final product. Next slide, please. So reach of the project, we published the final document online on its own website. You can see that there, snowhg.org/IDD, and sent it out to our partners on November 1st of 2024. We sent it directly to the IDD Advisory Group members, to the Snohomish County Executive Office and the Office of Social Justice, which is a group within Snohomish County that works specifically on social justice and equity issues. We sent it to the directors of the county's Health Department and Human Services Department. Staff from both departments were actively involved in this project. We sent it to all of the communications staff from the various departments and offices throughout the county. And we also sent it to all of the communications staff with our local health jurisdictions, which have a regular call where they convene to talk among each other. So we shared it through there. So 100 plus total recipients did receive this by direct email. I share that because that would not show up in the reach of clicks on the website since they would have also gotten it as an attachment. And then from our website since November 1st, the document has been downloaded more than 330 times. So we are seeing people download and make use of that document. Next slide, please. So this is a big lessons learned. And for this one, I will kick it over to Nicole, who, when we hit some bumps in the road, said, we're not taking no for an answer. We're going to make this work.
Yeah, and I just want to tee in on a little bit what Brandy sort of led with in terms of the challenges to doing stipending or reimbursements for lived experience. It is a challenge. I don't know, like it is a hurdle. In fact, I will just say, despite our successes with this program and this opportunity, we are continuing to run into hurdles within the county, the governance complex. And although I in the Snohomish County government sector, and I can share all my frustrations with that system, my experiences are not unique to us. These are experiences that many of our colleagues in the governmental space, but even non-governmental spaces are having these same challenges. And so, you know, although we were able to be successful in this project, it is an ongoing conversation. And so I just want to set the tone for you all as you unfold these challenges within your own organization and moving forward. You need to stay vigilant on the work and continue to push forward to create that change and that precedence to continue to fighting and moving it forward. So as Carrie mentioned, we were not as an agency going to take no for an answer for this. And so the county really has their mindset is really that it's a gifting of public funds. And that is essentially the challenge, is that reimbursements, the county concept and what we have available to us is really for reimbursements of services, if I will put that way, right? So whether that's childcare services, whether it's you need accessibility devices, however you're accessing, like we can pay for that, like a proportion of the bill. We can pay for mileage, right? There's systems set up for the things that backstop it. However, where the boundaries and the challenges comes in is if the thing is your skill set, if the service is your lived experience, that is not classified as a tangible that they can reimburse for. So that was really where the challenge, when we drilled into it, existed, is that it's not that they were opposed to the fact that individuals have lived experience. It's that in this space of heightened scrutiny for how public dollars are being spent, the tangible of someone's lived experience is not a tangible in the equivalency of mileage or wear and tear on a car or a cell phone bill, right? So that is inherently, that's sort of the challenge point. And I hope that might help you have different conversations within your sectors as well, to really get down to what is the unpeeling of the heart of the challenge. We said, okay, so we have a separate conversation moving on to change that culture within the county. In the meantime, we said, this is still going to happen. So we worked with a third party, the Sound Foundation for Public Health, which is a newer nonprofit that was started up for Snohomish County related to supporting public health. And the intent behind the foundation is really to leverage and do things exactly like this, that government has a challenge in doing. Community compensations, whether it is a $20 gift card, whatever amount gift card, tapped out on dollar values and other things, the flexibility of a nonprofit foundation or a fiscal entity that can do these for you became a very viable option for us. So we created a mechanism so that the foundation is the entity that is actually the ones giving the compensation to the individual on the board, on our consortium board. There are, of course, some hoops and hurdles that still need to be abided by, because there still are additional laws in place, regardless of the county space, that relate to taxing. As Brandy had mentioned, there are implications to benefits and other things like that. And so we wanted to stay below all of those thresholds that would trigger that. And in Washington State, and I believe federally as well, that limit is under $600 per year per individual based on that calendar year. And so we set our reimbursements to not exceed that. So, and then we also had additional criteria that were added in terms of, like, if this was a part of your already paid work, you were not eligible for these reimbursements and these stipends. So that was the process that was set up. Of all the individuals that we have, 3 were eligible, 2 declined. And so we moved forward with one person's reimbursements. And that process was all handled through the Sound Foundation. And so it wound up being a really good exercise for us to really twofold: one, pinpoint the actual pinch point within the county government to have that conversation of what is tangible and what's not tangible and how that's being viewed, and also to work with our Sound Foundation to really set up that mechanism differently and adhere to some of those guidelines, so we're not triggering other problems for our community members. And then I'll just leave this with, as this is a process that we are continuing to use for other entities and other community reimbursements and projects that we're doing with our community. This just was the first. And so this work really was groundbreaking for us to move this forward. So again, thank you all for this opportunity. And I know there'll be time for questions. So if you have any questions particular about this, I'm happy to answer those as well. And back to Carrie. Or next slide. I think it is back to Carrie, if I remember correctly. Yes.
Yes, and I will be brief here because we have a more important perspective than mine on this slide. But one of the other big lessons learned was just the connections. And so this project wrapped up late last year. We still have an active IDD advisory group list. So even though we're not meeting anymore, I get updates from folks on that list. I try to share updates to that list, and it's already paid off in other ways. So we have better visibility on needs and opportunities. And we've had things come up. For example, the county IT team reached out and said, hey, when we roll out new apps, we'd love to have someone actually test them for accessibility. Do you know anyone? And I was like, well, do I? I have a list. Sure enough, I sent out an email and said, hey, does anyone know anyone, or would anyone on this list be interested in helping with app testing? And someone got right back to us and said, yeah, if they need future app testing, let me know. So it's already paying off in other ways too, to improve accessibility. And it's just extended our reach with trusted voices, because the folks on that advisory board are trusted in their communities, and it's just an invaluable resource. But the better person to hear from there is one of our amazing connections who was kind enough to join us today. So I'd love to turn it over here to Todd, who is one of our advisory group members and showed up consistently to meetings and just brought the best feedback. So, Todd, can you take it away?
Thanks so much, Kari, and everybody who is part of this team. And as Brandy mentioned in the beginning, nothing about us without us is something that's been around for a long time. Having it be law in the state of Washington now it's an amazing accomplishment. I work for a Center for Independent Living. So what that is for everyone, if you're familiar, we exist with a staff and boards made up of people with disabilities, at least 51%. So it is disability led. I was also part of the founding of a coalition for inclusive emergency planning 10 years ago after the Oso landslide in Snohomish County. So in that, the work that we have done has been very inclusive of people with lived experience and subject matter experts. So to have this invitation was just a real exciting and music to everyone's ears to hear that we were going to have an opportunity to shape some of the tools and the guidances necessary to make effective communication part of the reality in Washington State and in Snohomish County. And as Kari mentioned, we are expanding this throughout the state, whether we like it or not. Everyone is enjoying the use of the guidance, and it is getting a lot more views than the 330 times that Kari has mentioned. I have myself shared it with folks across the country and national work that I do, and it is being well received and looked at as a model. As I mentioned with the coalition, we have as one of the pillars to our mission is effective communication. So we're looking at trying to keep our compliance with the Rehab Act. 508 compliance is part of this work. It was well covered and well received. Having people with lived experience is also part of the work that we've done within the Washington State Department of Health's Community Collaborative, where I'm a thought partner. And what we have been able to do there, as Nicole mentioned, is reimburse people for their lived experience to give input. I cannot say enough about how important this is because that perspective is something that is a relationship that has long-lasting effects. We are all under, the reality of federal cuts and trying to fix our own state budget, which has recently been signed. But to have people who are willing to show up and be part of the solution is giving buy-in and giving people with trusted voices to go back into the community and educate the people that need this the most, that need to be able to understand how their government and how their public health is working, to be able to understand how that is happening and participate in it. And that is a huge part of buy-in that I don't know that you can find any other way. The subject matter expertise I think that comes from the work that we've done here is kind of a launching point, and I think as we go forward, we're starting to see other ways that we can use the guidance as well as the model to be able to expand on the work that Kari started and my team here has started. So I can't emphasize enough how important this is. I just got off of Department of Health equity and social justice meeting just a little while ago, and I want to say to you the same thing I said to them. It's troubling to me to see government employees and people who do the work that you do that care genuinely for the public be talked about the way you have been in recent times. This is not not the community that we live in. This is not us. and it is certainly not you. And I want to say that the work you do is so incredibly important. Please don't stop. Continue inviting people with lived experience into these spaces. Thank you.
Thank you, Todd. That means a lot, and we so appreciate having you and those voices at the table. It was game changing. So just wrapping up here briefly, we want to talk a little bit about how this has changed our work for the better. I'll be very short and then kick it over to someone actually doing the work, our graphic designer, Sasha. But I would just say we catch a lot more things now based on what we learned through this experience compared to what we would catch in the past. Just within recent months, I realized when I opened our county's mission, vision, values page, which includes information about equity and accessibility, it was just an embedded image. As many of you know, embedded images are not necessarily accessible on a website. It was a simple matter, 10 minutes or less, to just take that text, put it in the web format with the proper headings and formatting so that it would be accessible, and have that image at the bottom as an addition, right? So it took 10 minutes, but it made the page accessible. And that popped into my head because I looked at that page and went, this doesn't line up with the guidance we just worked on. So we're catching things and making things that may seem like simple fixes, but until you know from the community that you need to do them, they're not simple. So it really has changed what we catch in our ongoing conversations when we talk about websites, social media, all of our tools. This is informing those now. And I'd love to turn it over to Sasha, who is a graphic designer working in both print and digital space, about some of the things she learned from this and how it's changed her work.
Thanks, Carrie. My name's Sasha Coffer, and I'm a graphic designer with the Snohomish County Health Department. This was a really fascinating project, and I learned a lot. And the biggest things I think that are also, I want to reiterate what I think Carrie said earlier about how this not only is, we focused on IDD communities, but this guidance really works for everybody. So one of the biggest things that we started out with, and I'm going out of order on the bullets. If we could do, was having things available to people in more than one format. Don't just have a printed thing, or don't just put it online. You might think it's just easier, but it's so much better to have, a printed poster and to have that information available online as well. Another thing I think we've talked about recently, and I don't remember if it was in the guidance or not, was talking about everybody's really excited about QR codes. QR codes don't need to be put online. The whole point of QR codes is to get a link to somewhere. So you don't need to use it online. But yeah, both the variety of print and web space, very helpful, especially things with social media using camel case. That's a really quick, easy thing that we can do to make it more accessible for screen readers, and so people can understand what, and I know that they're also using accessibility checkout tools in the various different softwares. I think that Todd mentioned earlier when we were meeting previously, there are so many different accessibility checkers right now in all the different software that it's hard to keep up. I mean, I tend to use one through Adobe Acrobat because Adobe is my bread and butter. And it's really, really valuable, and it can help bring up issues to me that we can fix. I would encourage everybody to use the tools that you can have, and there's a bunch of really great free ones. I know in our guidance we mentioned when it comes to design and accessibility, there's a color contrast checker that Adobe puts out, and it's free. You just upload an image and you say, here's the text color, here's the background color. And it either says, yay, you can read it, or no, that's not enough of a contrast. And it's really easy. I would encourage you to use those. So let me see if I got everything. Then also we have, and I've been doing this since actually before this guidance, super important, using inclusive imagery, because the best way you're going to get people to accept your message and really buy into your message is by feeling like it really pertains to them. They see themselves. They're reflected personally. And all those different ideas, whether ability, race, ethnicity, gender, age, all those different things. And of course, tailored to your specific audience about. In our case, okay, are we looking for maybe an audience that's going to get a specific vaccine for a specific thing, and maybe it's for babies. Well, we're going to go for a younger audience. Let's see, did I catch? I believe that I got almost everything, but those were the big points that we learned and that I use in everything going forward. It's been really, really helpful for me in that. And also learning about with alt text, there's also a variety of, I know some people, it could kind of be preference on how descriptive you want to get, which was also really interesting. And if something is just decorative, or if you don't want to put a description on it, or you don't think it needs a description, you might want to just consider not using it. So the value of
excuse me, this is Brandy. This is Brandy. Real quick, I want to make sure folks have enough time that are going to go after us. I'm sorry I'm interrupting you.
Oh, no, you're fine.
Yeah, that's cool. Yeah, cool. We ate up a bunch of time, so I just want to say your ideas and the ideas that you're sharing are all in the document. You folks have a link to it to go see more about how and what we are suggesting you consider to make your information more accessible at your public health program. And thank you. And I'm sorry to interrupt you. And thanks everyone for coming. Yeah.
Thank you all for presenting, Kevin, Brandy, the Snohomish County team. We really, really appreciate you. If you have questions for them, be sure to put them in the chat. They will follow along and answer questions as they can if you have any questions for them. And we're going to move to our next presenters, who are from the Puerto Rico Council on Developmental Disabilities. So Liz and Alexandra, you can take it away.
Thank you, Amy. Hi, everyone. My name is Liz Candelario Garcia. I'm a Latina woman in my 30s. I have dark hair and I wear glasses. Today I'm wearing a blue blazer. I serve as the Executive Director of the Puerto Rico DD Council. I'm very happy to be here with all of you today. Now, I'd like to take this opportunity to share with you a topic that we are passionate about, and it's very important to our community, training healthcare professionals about the proper case management of people with intellectual disabilities. Next slide, please. Well, first, I will give you a quick overview of what we will be sharing today. We will start with the main objective behind this activity, the reason why we are here. Then we will talk about the strategies we use to develop a training program for medical professionals. We will also explain the curriculum which was created using a toolkit and how it connects to the survey's result we collected. You will hear how we motivated doctors and health professionals to take part in this training, what results we have seen so far, and finally, what our next step will be. Next, please. Well, our goal is to make sure by the 2026, people with IDD may have greater access to the services they need to live meaningful lives by accessing system barriers to opportunities and benefits, and advocating for at least 4 system change initiatives to address systemic change with partners and allies. Next, please. Why Objective 2D was created? Well, first, in April 21, Federal Monitor Alfredo Castellanos reported the lowest compliance level in 22 years, only 9%. Second, our council met with the Health Department Division of Services for Persons with Intellectual Disabilities and provide database technical advice. Third, we identify a clear gap. Many health professionals had no training in communicating with or treating adults with intellectual and developmental disabilities. Therefore, we developed an evidence-based training program to raise the quality of care. That is the focus of today's session. Next, please. Okay, let me share some of the gaps we identified. First, Many healthcare professionals lack training in case management for people with IDD. Second, there are still misunderstandings about their abilities and the quality of life they can have. And finally, Puerto Rico Department of Health have said it clearly, there is an urgent need for training, especially for doctors, pharmacists, and other providers. Next, please. The strategy and training we developed came from a great collaboration with the Puerto Rico USED. We aligned it with best practices, including the Vanderbilt Toolkit and the 2019 Core Competencies on Disabilities. To understand the real needs, we did questionnaires with doctors and pre-therapy clinics, including those that serve in the island municipalities, Vieques and Culebra, which are our targeted disparity. Next, please. As part of this effort, we created a curriculum that provides 28 contact hours of training. The training includes essential topics like the definition and coexisting condition related to intellectual and developmental disabilities, an overview of loss and service models, for example, medical home, how to manage behavioral crises, how to offer care that is based on evidence, and also how to manage medication appropriately for this population. Now that we have reviewed the context, the strategy behind our training, and the curriculum goals, I would like to turn it over to my colleague, Attorney Alexandra Mojica. She leads the planning area. Alexandra will walk us through the core competencies we use, the curriculum derived from the toolkits, and how all this connects to the survey results and the impact we are seeing so far. Thank you.
Thank you, Liz. I am Alexandra Mojica. I work at the Puerto Rico DD Council as senior attorney, and I am the lead in all of our planning aspects. I am a 35-year-old Latina woman with dark brown hair and pale skin, to provide a description. So, as Liz previously mentioned, we used already developed core competencies and tools to develop our curriculum because our intention was really not to invent the wheel, but rather to adapt the wheel to be able to navigate properly with the healthcare workers in Puerto Rico. So we use these core competencies that were developed by the allies of healthcare through a national consensus process, including 152 stakeholders, to establish a baseline expertise, a guide, and some values that we wanted to instill in the healthcare providers that took the training. The first is that culturally and linguistically competent care for patients with disabilities means that recognizing patients of diverse backgrounds are influenced by multiple social, economic, and cultural factors, all of which must be included in the comprehensive view of their health status. The second thing was that people with disabilities should have equitable access to appropriate treatment, that people with disabilities face barriers in accessing effective healthcare that may or may not be associated with their disabilities, that healthcare providers can maximize their patients' quality of life by preventing and treating those health conditions, and that people with disabilities are knowledgeable of their conditions, and this expertise should be respected and used to improve the healthcare decisions and their care. Next slide, please. We also believe that the quality of life and treatment goals should be incorporated and reflect the patient's point of view, that healthcare providers should communicate directly and respectfully with the patient with disability and include them in the decision-making process, that healthcare providers should know under what circumstances caregivers should be included in decision-making and encounters, that providing the optimal patient experience means creating a respectful, accessible, and welcoming office environment that uses universal design principles, and that accessible diagnostic equipment and techniques are essentials to quality healthcare for patients with disability. Next slide, please. So using these 4 principles and the Vanderbilt toolkit, the needs we identified through the survey to healthcare providers in Puerto Rico and the meetings that we had with the representatives from the Puerto Rico Healthcare Department, we came up with this curriculum that included 7 sessions. The first session was titled Intellectual and Developmental Disabilities and Comorbid Conditions, and it focused on identifying definitions and demographics of intellectual and developmental disabilities, helping the healthcare providers understand medical comorbidities that may affect adults with IDD, describing clinical challenges and potential beneficial accommodations for patients with IDD. Our second session focused on the service models and laws related to developmental disabilities, where we discussed some of the main models that are used for care: family-centered, person-centered. The third session was the transition from pediatric to adult healthcare, and identified the skills and support that were needed for a successful transition to adult life healthcare. Next, we have managing a behavioral crisis in people with intellectual and developmental disabilities. This session was a response to one of the main needs that was identified through the surveys that we did to the healthcare providers, where we explained some of the possible sensorial and behavioral challenges that people with intellectual disabilities may face in a clinical setting and how to work with them. The fifth session was titled Violence in People with Intellectual and Developmental Disabilities, and it focused on explaining the factors that make the population vulnerable to violence and identifying which elements of adequate service for people with intellectual disability with an inclusive vision of equity and independence would provide that adequate care that they need. The sixth session was Preparing to Care for My Patient, Appropriate Evidence-Based Practice, and it described accommodations and support that providers may need to implement when providing care to people with intellectual disabilities. Our final session spoke about medication management by people with intellectual and developmental disabilities and their support network. Here we identified points in the medication management process where problems may occur and opportunities to facilitate the safe and effective medication practices. And this came from our meetings with the Puerto Rico Healthcare Department, where they did extend and informed us of a preoccupation where sometimes healthcare providers didn't necessarily look at records from other healthcare providers in terms of what they were prescribing, and polypharmacy could be caused. Next slide, please. So to motivate Puerto Rican healthcare professionals to participate in these workshops, we got them submitted and approved as continuing education courses for various professions, such as psychology, social workers, physician, nurses, speech pathologists, and occupational therapists, and nutritionists. In regards to physicians in Puerto Rico, they need to complete at least 30 hours of continued education every 3 years if they want to get their license renewed. So this training was a way where they could comply with some of the hours that they needed for that requirement with no additional cost to them. And that really got a lot of people interested in the training. We can go to the next slide. So in terms of evaluation methods and participation, 90 healthcare professionals registered for training. Our target for this year was 50 healthcare professionals trained, and we got 55 to complete the training and receive continuing education. To evaluate the effectiveness of the trainings, we used the attendance records, pre and post test, and a satisfaction survey. The average pre-test score was around 7.14, and the average post-test score was around 8.39. So after running all of the pre and post-test scores through a pair t-test comparison, the user was able to determine there was a significant knowledge increase of 17.41% in the participants that took the training. Next slide, please. Regarding the satisfaction survey, it included 12 premises, and participants could choose if they strongly agreed, or disagreed with the premises. I do want to state that no participant disagreed with any of the premises, so I am going to read slightly some of the premises that were presented to them that they either strongly agreed, as you can see in the slide, or agreed with. They believe that the activity met the objectives, that the activity met their training needs, that the examples discussed facilitated the understanding of the topic, that there was a good time distribution, that their knowledge increased by participating in the workshops, that the materials provided a greater understanding of the topic, that the activity stimulated their willingness to put into practice what they had learned. And we can go to the next slide. That the workshops helped them improve evidence-based practices, that the information would help them work better with other people that serve people with intellectual or developmental disabilities, that they could use what they learned to better support individuals with intellectual disabilities and their families, and that they would recommend the trainings to others. Next slide, please. So what's our expected impact for this project? This is an ongoing project, and it will end with our state plan in the fiscal year 2026. As you can see, the trainings were a success. There was a significant knowledge increase post-training. So we are trying to improve healthcare providers' knowledge and confidence so they can provide adequate treatment to people with IDD on their island. And we want to advance systemic change in how adults with intellectual and developmental disabilities receive healthcare services in Puerto Rico. Next slide, please. So during the next fiscal year, we are gonna do a follow-up survey to the participants to know if they are implementing these quality standards that they learned through the training workshops. And we will also be implementing the workshop trainings with at least 50 new healthcare professionals. And in 2026, we really want to check in with persons with intellectual and developmental disabilities and see if we have managed to create a systemic change through surveys and other quantitative investigations. So that would be it for our presentation. Thank you all for taking the time to listen to us, and I will give it back to Amy.
Thank you so much, Alexandra and Liz, for presenting about your project and the work that you're doing in this area. It's very interesting work that you're doing, and glad to see you're having such great results. Next, we're going to hear from Christy Ashley, the Executive Director of the Mississippi Council, and she's going to present on her Project Grow.
Hello, everyone. Thanks for being here this afternoon. I'm Christy Ashley. I'm the Executive Director for the Mississippi Council on DD. I'm new in the Executive Director role, but I've been the Program Coordinator for the Council for the last 14 years, so it's not exactly new, just a different role. But Project Grow, that came about from Vicksburg Family Developmental Services out of Vicksburg, Mississippi. So what we did is sometimes we will put out a request for proposals called Innovative Quality of Life Grant applications. And these are just to kind of do some small time demonstration projects that are anywhere from 3 to 12 months that kind of hit on specific needs that we're learning about or specific needs different counties across the state are having. Next slide, please. So that's how Project Grow came to be. So Vicksburg is in Vicksburg, Mississippi, which is Warren County. Warren County is located on the southernmost edge of the Mississippi Delta. Out of that county, 41.3% of its children live in poverty and 51.9% live in single-parent families. So of the families served just by Vicksburg Family Development Service, 33 of their parents receiving their prevention and early intervention services have a developmental disability. And 99% of those parents are single parent households, and 99% received SNAP benefits. Well, what they noticed was that in serving these families, more and more of those parents were coming to them with the need in assistance of buying more food because their food was not lasting until they got their next allowance from their SNAP benefits. So they reached out when we put our RFP out and done a proposal to educate about nutritional, reading labels, and just educational stuff. Next slide, please. So further investigation revealed out of the families asking that most of those parents were households of parents with DD and children with DD. The parents did not know most of them did not know how to cook, read labels, or shop for nutritional foods, healthy foods that would help make that budget last. Next slide, please. The Project Grow was born. So their overall goal was to promote better health and wellness among participants through education in nutrition, shopping, and food preparation to increase food financial stability. So it was trying to get them to learn how to shop, read the nutritional labels, and prepare meals that would further them through the month till they get their next assistance. Next slide, please. So objectives consisted of making the participants would learn how to make healthier lifestyle changes, and they would gain knowledge of how to shop for healthier, reasonably priced foods to sustain within their food budget while also preparing meals that the family enjoyed. This would be done through coming together for classes and doing actual hands-on demonstrations. So items were actually bought, and then during the classes, they would actually cook these meals to get this demonstration. Next slide. So the planning began then. So activities were based on identified needs of families and the SNAP Ed Cultural Heritage Evidence-Based Cooking and Education Curriculum. They would enlist the parents with DD enrolled in Vicksburg Family Developmental Services to participate. But of course, everybody that they served was also eligible to participate if they wanted to. They already knew from serving these individuals through various programs that a barrier was childcare and transportation. So they already knew they were going to provide childcare and transportation to eliminate, not being able to participate. They would provide 6 cooking classes that were also educational in relation to learning about food labels and comparing the prices, such as brand name versus generic. And then at the end of the program, they would have a shopping trip planned for the last class where they would shop and demonstrate what they had learned through these 6 classes. Okay, next slide. So the SNAP Ed was designed to increase fruit and vegetable consumption. It would increase confidence to plan and prepare meals at home, and it would also incorporate physical activity to try to get them to move at least 30 minutes a day most days of the week. It consisted of 6 two-hour sessions with nutrition content that was derived from dietary guidelines for Americans using the USDA's MyPlate materials. It incorporated the social cognitive theory of change, where the learning occurs in social contexts with dynamic and reciprocal interactions of the person, environment, and their behavior. So it was trying to change the interaction and change behaviorally for long-term effects. And it was designed as a hands-on interactive curriculum where the leaders would model the skills and behaviors they're teaching. So not only were they teaching it, but it was being reciprocated because the participants were actually doing it as well. Next page, next slide. So each class included review and introduction. So participants would engage in icebreakers and introductory knowledge assessments. They were all included in food preparation, safety skill development. They were all required to participate in food safety and sanitation skill development. They would discuss dietary guidelines and they were also presented with question and answers. Strategies were introduced and established in regard to meal planning, budgeting, and purchasing. And then the importance of physical activity was addressed and individual planning of weekly implementation. And then at the end of each class, participants were asked to self-reflect and taught how to journal their thoughts and emotions and assist with goal setting. So like the first class, they would do this, but the second class, they would talk about what goals they met, challenges they may have, and then they would talk about through some of those challenges and see how they could reduce the challenges for the next week coming back. So it was trying to help them also navigate through some issues they were having meeting what they wanted to do. Educational portions consisted of like examples of giving them portion size. Like not everybody has a kitchen scale, and it would be very difficult to carry the scale to the store. So we tried to give them concrete visual aids to determine this, such as 1 medium apple equaling the size of a baseball, or maybe 3 ounces of lean meat would equal the size of a deck of cards. They discussed dairy, why it's important to drink dairy, how much is needed daily, what counts as a cup in the dairy group. Most of these parents have children, of course, so we talked about strong bones for their kids. We talked about calcium and how much the kids need daily depending on their age and how much of that is a serving. Tips were provided on how to incorporate the calcium into the child's diet, such as making smoothies with fruit and yogurt instead of doing like an ice cream and milkshake type thing. We talked about using yogurt as a dip for fruits and vegetables instead of the chocolate dips or the caramel dips. Nutritional value of vegetables. We talked about health benefits, how to select fresh vegetables at the store, and various cooking methods, and how much daily servings of each of the food groups that you would need. And we did the same with the meats. We talked about what meats were the leanest, what the healthiest meats were, and the healthiest cooking methods. Next slide. So they also completed evaluations. They did pre and post test administered through questionnaire and conversation. So the pre-test was to gauge their base knowledge on what they thought about nutrition, what they needed for nutrition, and how their current lifestyle and eating habits were. And then after the 6 weeks program, they talked about identifying 2 changes in their shopping and preparation of the foods, and 2 ways they plan to continue to implement these changes. And this was actually completed, I don't know if any of you ever visited Vicksburg, but they have a catfish museum that had been remodeled and put a kitchenette in there. And so they had actually let them come into the kitchen and do these classes each time. So not only do they get to participate and tour the museum and learn some about the history of Mississippi, but they also got to use that very nice kitchen. So next slide. We had 12 parents participate and 8 participated in the end of program surveys. And they have a lot of varying responses, but the most popular responses were that they learned to read the labels and compare the nutritional values. And they learned of a new cost-effective meals to prepare for their family. And then everybody learned at least 1 meal that they could prepare at home that the families liked that would decrease their number of fast food trips. Because that's really what we learned, that most of them, not only due to not cooking and not having enough money, but it was just easier for them to drive through a drive-through and feed their children instead of go home and fix a meal that would feed everybody that was much more cost-effective for the family. Next slide. So some benefits that came out of this program was that the participants increased their wellness due to diet changes, food preparation, and physical activity, improved financial stability and the ability to further their SNAP benefits through the month purchasing healthier, easier prepared food items. And then for not only the participants, but everybody involved, also it increased the awareness of a need that's sometimes overlooked in the population. And some things that come out of this that we didn't really, it wasn't thought of in the beginning, but some families were taught, your leftovers. What can you do with your leftovers? Well, a lot of the vegetables, you can put them in the freezer and then pull them out, put them all together to make a mixed vegetable soup in a crock pot. So that would feed a family and last a bit longer. And just general, like the safeties of freezing food, what things can be frozen, how to thaw out, reheat foods, what to do with leftovers, just stuff like that to help prolong their budget. And that's really all I have. It was a real interesting outcome. The families enjoyed it. After participation, they did get to leave with everyone got a crock pot and they got cooking utensils to use. So they did walk away with that. Even now, they're still continuing this program. They follow back up with the initial participants just as a refresher course to see if there's any questions, if they're keeping up with their exercise, if they're keeping up with that. They did make a cookbook. They come up with some recipes, some healthy recipes. a lot of the parents, they do work, and so timing was an issue of coming in, cooking in the afternoon. So a lot of their recipes they came up with were being able to be done in a crock pot. So that was real helpful. Amy, I'll turn it back over to you.
Great. Thank you so much, Christy. What a great project, and certainly needed in not just your state, but probably most states. Okay, so our final presenter today is going to be Dr. John Behrens, and he's going to talk about a project that he worked with the Texas Council on. Dr. Behrens, are you ready? Take it over.
Thank you. Hi, everyone. It's really nice to be here. I really appreciate the opportunity to speak and talk about this project. Let me share my screen here while I get everything ready. So, first of all, everybody see slides okay? Okay, great. So I'll just introduce myself really quickly here. My name is John Behrens. I am a physician. I did my training in internal medicine and pediatrics, and I work at Baylor College of Medicine in a clinic called the Transition Medicine Clinic, and we take care of adults with intellectual and developmental disabilities almost exclusively and provide primary care to that population. So my project, and this was very much a interdisciplinary team effort. My project was in regarding improving health, oral health actually, disparities for adults with intellectual and developmental disabilities, and I'll abbreviate IDD for the sake of brevity for this talk. And so a big thanks to all the people who were a part of this in terms of especially funding from TCD, as well as the WITH Foundation provided some funds for this project, and then many people to thank from across multiple institutions, including behavioral therapists from University of Houston, Clear Lake, my mentor, Dr. Peacock, and then also some dental colleagues over at the University of Texas Health School for Dentistry, Dr. Frey and Dr. Warner. So the goals today for this talk, I want to at least give some context of what we're doing and why we did what we did for this program. I'll talk about the program itself and at least give some broad overview of the results of what we found. And then, sort of putting it back out into the world in terms of what do we do with this information, try to give some sense of, possible future directions and some needs that we identified from the results that we got. The population we're going to be talking about today is really focused more on adults who have IDV. And the reason for focusing on that population, particularly in adults, is we know that there's a lot of oral health disparities for adults with IDD. You look at a lot of different angles. There's more dental caries or cavities. There's higher rates of tooth loss.
Gracias.
A lot of the other markers of oral health are a lot lower, and just the actual getting dental care is a lot harder to achieve. And when we're talking about oral health, we're not really just talking about quality of life, although that's a huge thing and it's very important. And oral health quality of life is really, really impactful. If anyone's ever had a toothache, like you can speak to how it's so hard to do anything else when you have that dental ache to deal with. But this is impactful to someone's overall health. We know fairly concretely that someone's oral health has a very significant impact on their overall health, increasing levels of inflammation. There's associations with diabetes and heart disease. So this really matters not just for the mouth, but really for the wellness in a really complete sense of the word. So this matters. Even when we start to step out of the individual and how impactful and important oral health is there, when we start to think about health systems and start to think about big picture implications of these issues, there's huge financial implications. This data is a little bit old now, but I think it's really still illustrative and worth talking about. This is from the Texas Health Institute. So just talking about Texas, over about a 10-year period, there was over $1.5 billion in hospital charges for dental conditions that were non-traumatic, meaning it's not like somebody fell and they broke their teeth on the sidewalk and they needed to go to the hospital to get that fixed right away. This is something like someone had a cavity which didn't get fixed in time and developed into an abscess, which developed into a bloodstream infection, which led to a hospitalization that required a lot a lot of pieces and a long stay and all of that. So when we look at that and we try to divide it up by just looking at Medicaid alone, and the reason I did that is because, a lot of people with disabilities, utilize Medicaid services. In Texas alone, we're talking about um, $20.5 million a year of Medicaid charges for these dental conditions, which is huge, right? So this has an enormous financial impact, and I'm sure that number, I would guess, is a lot higher now with inflation and just everything else. But even if it's static, that's an enormous number. So this has a big impact both on the individual level as well as on health systems and just health costs. I think it's important to step back with that information in mind and think about what's feeding into these shortcomings. Why is there such a gap here? Why are these things so impactful and so challenging? I think there's a lot of different pieces here. One is just thinking again at the individual level. For people with IDD, there may be physical and or cognitive disabilities. So if somebody does not have the motor control or coordination to brush their teeth, that may make it harder to get good oral care in the home. Maybe they're not able to understand the steps required to brush your teeth in a really rigorous way. Maybe there's medical conditions that make it more likely to have dental issues. If there's really, really bad reflux, for example, that can lead to dental erosions and a lot of other problems. And then a lot of people that I see in my clinic are on medications that affect the oral health. So a lot of medicines can make the mouth drier, which leads to higher risks of cavities and things like that. Other medicines might actually cause gum disease and issues with the gums. So some of these are really at the personal level, making people more likely to have dental disease. But there's a lot else at play here. I think access to care is a huge one, and I see this on a at least weekly, if not daily basis. My patients looking for access to a good dentist, and I think it's important on a couple levels here. One is, okay, do I have any funds to pay for dental care? Now, depending on the state you're in, if you're on Medicaid, some states at least have a carve out of some funds available for dental care. So in Texas, for example, if you're on certain Medicaid plans, you will have $500 to pay for kind of routine dental care, which is great and certainly better than nothing. But at the same time, a lot of dental care is very expensive. And so if you need anything beyond just the regular cleaning and x-rays, like that's probably not going to get you very far. And again, some states don't have any of those funds available. So how do you even pay for dental care? Assuming you can, if you have the ability to pay for in one way or another, being able to find a dentist who is able to sort of provide the appropriate care you need is really, really challenging. For one, there's some studies and some good data that shows that not a lot of dentists take Medicaid. So nationwide, less than 40% of dentists take any Medicaid patients who have Medicaid. So even if you have Medicaid and that's paying for your dental care, it's not always easy to find a dentist who might even accept that payment. For dentists who are willing to take your form of payment, whatever it is, finding a dentist who has, especially an adult dentist, who has training and knowledge and comfort and confidence to address some of the additional complexities that often come from individuals who may have behavioral issues or cognitive disabilities or just medical complexity. Like these things can make it hard to find a dentist willing to accept that patient. And the behavior issues in particular can often be very daunting, I think, especially for dentists who might not have that experience. And when we talk about behavior issues, we might be talking about uncooperation, right? So like I don't want to do what you're asking me to do. Or it might just be disruptive behavior. Maybe like I have no problem being in this dental chair, but like I don't really want to sit still and I don't understand the prompts that you're asking me to do. And a lot of that seems to feed from anxiety related to the procedures, which might be environmental. There's lots of sounds, the drills, the smells that are happening, the bright lights. This can be really daunting, especially if people have sensory, sensitivities. Um, and a lot of it's just scary, right? And we'll talk about that in a second. The end result, though, of all of this, where dentists don't feel like they can provide the care they need for these issues, they end up a lot of times using measures like sedation, so like IV sedation, in a chair, or even general anesthesia, like in a hospital setting, or restraint as well. What ends up happening, I think a way to think about this in a very broad viewpoint here is that if you have an individual who has increased discomfort and anxiety in the setting of dental care, and that can be a variety of reasons like we've talked about, whether it's the stimuli around them or just I don't have control over the situation and it makes me very nervous and uncomfortable. The problem is that over time you start to pair those negative feelings with the dental environment, and those two things start to come together. And so in the future, it makes it even less likely that you're going to want to cooperate or even want to step foot in the dental office because you, as that person, have started to pair those negative feelings with this place. And so therefore, it's just going to get worse, and those feelings are going to get stronger. And then the behavior issues and perceived, uncooperation and stuff gets louder and stronger. And so it ends up with over reliance on those measures we talked about, like restraints or sedation or anesthesia. And so that's kind of where we are for a lot of our patients, is that the patients that I see, a lot of these individuals, this is how they get dental care. And the problem with these interventions is not that they don't work, but they're not risk-free for sure, and they cost a lot more, which makes all those other access issues even more of a challenge. So could there be another way? And that's sort of where our project comes in. Our intervention was the end result of a lot of different people coming together and saying, how might we address this issue? So we had the medical team, myself, representing, the medical side of things. We had dentists, we had behavioral therapists, we had families and self-advocates to weigh in about our project. When we came down to it, what we really wanted to do was target people who were getting those more advanced measures for just routine cleaning, not even for like, big invasive procedures, root canals or whatever. This is just, when I get my teeth cleaned at the dentist, I need to be sedated. So we wanted to target that group of people to see, with our intervention of increasingly, intensive behavioral therapy strategies, could we actually convert or be able to achieve a cleaning without needing those more advanced measures in sort of a more traditional way, just using behavioral supports. So that was kind of our primary aim. So what did we use as the behavioral strategies? The basic package, that everyone who kind of came into the door, these were the ones that they got. And the reason that we included those for everyone was because these are things that are very straightforward, as you'll hear in a second, and I would argue are very doable by kind of anyone, even with very minimal training. This is not something that requires a degree in behavioral analysis to be able to provide in a fairly consistent way. So everyone who went through this project got the following. They got frequent breaks, meaning we're going to just do things in small chunks. I believe we did every minute or so, just a really quick pause, maybe with longer pauses built in. And you didn't need to earn those. You didn't need to act out to get those. We just built those in. So we went on a little bit of a chiller pace. We gave you praise when things went well. So we're really trying to reinforce, hey, this is a positive thing. We are glad you're doing the step we need you to do. This is something to be celebrated. So lots of praise. Tell, show, do, which is a strategy where instead of just kind of launching into, the scrapey scrape part of the dental exam or the washy wash part, we're going to tell you what we're going to do first. So the next step is I'm going to scrape your teeth and I'm going to show you the step, either just the tool that I'm going to use, or I might even demonstrate it on a, little tooth model that I have or your stuffed animal that you brought with you. And then I'm going to actually try to do it. And we didn't just kind of give up after the first try. If there was any indication that the person didn't want to do it or, pushed away or leaned their head away, we gave a break. We tried again. We gave a break. We tried up to 3 times and at least gave the person, 3 opportunities to try to engage in that step. The last thing we did, which I think is a little bit more counterintuitive to some of these other steps, is to not have escape prevention. And escape prevention is saying, well, if you don't want to do something, if I don't keep you in the room, then you're just going to leave, and then that's it. The problem is that if we're really trying to peel back these layers of lack of control, of trauma from past procedures where you felt like something was being done to you against your will, where you didn't have control over the situation, giving control back to you is key to undoing that. It's key to building that trust again. And it's not until that trust is built that you're going to be okay with what's happening in front of you, where you can allow the opportunity for cleaning and realize that, okay, these people are not trying to hurt me. This is going to be okay. So the way to do that is to allow escape prevention, or sorry, to allow escape, right? So if you don't feel safe enough to be in the room, I'm not going to retain you in this room against your will. And I think that the reason it's counterintuitive is because a lot of studies, when they're trying to change behavior, really do generally prevent escape, with the thought that just we're never going to get anywhere if we can't even keep you in the room. But what we found is that that's not necessarily the case, at least in this setting. If all of these basic strategies didn't work, the next one that we really focused in on was just allowing access to a preferred item. So if you really like a certain TV show, please bring your iPad, bring your telephone, and put that show on, not just like put on Netflix, but put on your favorite show or your favorite episode even, or maybe even your favorite clip of your favorite show and put that on repeat. Whatever it takes to make you feel comfortable and happy and maybe distracted, we want you to have access to that. We didn't do that at the start because that one, I don't want to say is hard. It's easy to allow someone to do that, but I think it's a little bit more nuanced, right? Because you want to make sure that we are really getting to a preferred item and not just like some random distraction thing that may not actually be that helpful if it's not what the person truly likes. In terms of just the process, this is a quick map to show, we started by doing an evaluation. Part of the project was done pre-COVID, and so we did a lot of pretty much everything in person at the start. So we did an initial evaluation in the office, and if that didn't work, then we did more work with the behavioral therapist working on practicing these steps. Once COVID hit and we had to pivot, of course, and so we ended up doing a lot of the initial evaluation and training at home with the behavioral therapist via Zoom. And so on the left side, you can see the evaluation at home was sort of this initial step that fed into the eventual evaluation in the office. And then again, if that didn't work, we went back to more behavioral health services via Zoom. If things went well and they were able to cooperate with the full steps of the exam, then we actually referred out to the community beyond just the confines of our dentist and our project. And I think it's important to note that our dentists in the project have a passion for caring for this population. They have experience in caring for this population. So it may not be fully representative of a dentist out in the community. And so we felt like we needed to also, after this step passed, we needed to also see how does this look once we sort of set you free, right? Does this translate to success in a more generalized setting? To get to the results here, so a lot of participants came through this project. We had about 80 in the years we were running. And thankfully, we had a nice split between people working virtually and people doing this in person pre-COVID. We had about half of the people that went through this program who did end up with successful dental exams with the dentist in our project. Now, the other 50%, it's not like they were unsuccessful. We just either lost them to follow-up or they just were still in that kind of training and practice phase and just never quite got there. At the end of the funds, we still had some people who were sort of left and are available, maybe for future projects. But of the people who were successful with that initial dental exam, I think the real key thing here that I would highlight is that about half of those people were successful with like the base package, right? So it's not that people got to the point of success with the dental cleaning with the dentist after months and months and months of practice and all these fancy strategies. No, these are people who had that base package of just these simple, straightforward interventions. And of the people who were able to be successful with straightforward interventions, a lot of them actually did great when they got to the community dentist. Not everyone, but most of them. The other interesting thing here too, comparing just the group of people who did all of this virtually, or at least all the prep work virtually, versus the people who did the initial assessment and the practice in person, they looked at the same. So basically doing things virtually, it was not inferior quality, right? It was just as good as doing this in person. So what does this all mean? The bottom line is that these suggest, and they're early, they're preliminary, but they suggest that we as a whole are relying too much on sedation, on anesthesia, on restraint. And there's an opportunity here to really improve short-term costs with a little bit of intervention, right? If we're able to employ some of these strategies and give people a chance and have dentists who are invested and able to just allow for the opportunity, I think we could make a big impact even on a very short-term level. In the long term, there's a lot more to be done, and I think we could really improve utilization costs. I think we could really improve oral health quality of life. There's lots at stake here that can be improved. Again, not with necessarily huge interventions, but we do need some things, right? We need dentists who have training and comfort. We need training opportunities both for dental students as well as practicing dentists, which some of that's been underway since this project. And we do need better reimbursement models, right? Like if they're going to be dentists who are taking the extra time and allowing for the possibility that I won't be able to bill for this visit because we are still in that practice mode. Why shouldn't I get reimbursed in a different way from my quick, visit where I can just kind of get the person in and out without any extra considerations or training or support? We also really need to beef up our behavioral therapy services to be able to just access them better and help with the training and be able to reimburse for those trainings so we can get to the point of lowering the need for those more advanced measures at the dental office. There's other things too in terms of trying to combine dental and primary care and work together in a synergistic way to be able to research these models a little bit better and look at a more long-term way, as well as the actual cost savings that might exist for models like this. And in the future, we might even use these similar models with other types of noxious or invasive medical procedures. Some of these are already underway after this primary project ended. As well as we did create an online training that hit some of the highlights of what we learned there. So if you want to see that, that QR code will get you to the YouTube video that does show also some videos from the actual project, as well as a lot of the highlights and the things that we learned. I'll leave that up while I go through my conclusion just really quick in case anyone else wants to snapshot it. But I would conclude by saying that it's really important to note of these ongoing health disparities, right? They're really significant and they really matter on a both individual and systemic level. And I think that behavioral therapy services might really serve a crucial role, not only in helping to decrease the need for the sedation and the restraints and the anesthesia, but also as almost a triage method, right? Like if a behavioral therapist is able to see an individual and say, hey, you know what, I think you're going to be fine. You just need to find a dentist who does some really basic things. That's a great use of resources to be able to decide who might need more prolonged behavioral therapy services or may never get to that point versus someone who really is not going to need much. We just need to give that person a chance. And help us to stop relying so much on the sedation and anesthesia measures to be able to get better, safer access to dental care, and in the long run also help with, long-term health outcomes and cost outcomes. But we need more dentists, we need more behavioral therapists, we need more research to look at this, and we need to spread awareness of these needs and some of the more high-yield interventions. So with that, I will stop. There's my email if anyone has any follow-up contact. I don't know if there's time for questions. I'm happy to stick around if there is time here for a little bit. Thank you, everyone.